Hey everybody, I'm your four-eyed professor, Chris Lievens, and I'm super excited to talk to you today. Our roll call is for new and experienced ODs, optometry students, and even those just interested in this profession. We'll cover a number of topics together, and I'll help you see them through a professor's eyes. Please take your seats. School's in session.
Thanks everybody for coming back to the podcast. This recording, I actually have a special guest from Ohio, Dr. Tim Earley, and we're going to cover a topic that we've not touched on before, and that's electrodiagnostic testing and electrodiagnostic testing in typical optometric practice and how it's being used today and what we might see coming forward in the future. So please let me welcome to the stage Dr. Tim Earley. Hey, Tim.
Hey, Chris. Thanks so much for having me. I appreciate it.
No, I'm glad that we got to connect and schedule this time, and it worked out for the two of us. So for those people who are attending, both audio and visual, please let them know a bit about you.
Sure. So first of all, I got to say, I met Professor Chris Lievens years ago, just doing some consulting work for one of our industry partners. And it's great to be back on with you, Chris. Our paths have crossed numerous times, and the topic you're going to have me discuss today is something I work with daily in clinic. So thanks for having for getting me on your podcast. I appreciate it. The way I describe myself is I'm a general run-of-the-mill primary care optometrist out in a town called Medina, Ohio. And I've been in practice for about 26 years now. It's a single location practice that we're now part of a bigger OD-MD group, but it was a single location practice for about 23 years or so. And just between you and I and your listeners, I've always been a bit of a nerd when it comes to technology. I've loved to embrace new technology, but I'm a big fan of making sure that it fits patient flow and has a place in the practice that actually adds value to the patient experience and also to our ability to diagnose and manage and treat eye diseases. So
right.
The device we'll talk about tonight, that it kind of fits, it checks all those boxes for me. So
yeah, I would say in that respect, Tim, I'm a lot like you. I always wanted to be the earliest adopter, and if things didn't pan out or it didn't take hold, so be it. But at least we had our hands on it and opinions on it first. And but many times things do take off, and then to have first opinion and first experience, it really puts you in a great perspective to share with your colleagues like we're doing now, but also puts you in a great experience to promote to your patients. It's exciting to the practice to always be first.
Yeah, absolutely. I couldn't have said it better. I feel like there's been some technology that we've embraced that, oftentimes, while it was a good technology, it might not have been, an easy test for a patient to perform, for example, or it might be a very subjective based functional test or structural test. And sometimes you get good information, but the poor patient can be tortured through the process. Right. So it's fun. What I enjoy is, industry is typically, pushing, things forward in a way that allows the patient experience to be improved, but also it allows for efficiencies in our clinics. And then that's important. There's not an optometrist out there, as you know, who wants to bring in a device that's going to add time to their patient visit. We just don't have that time anymore or that luxury anymore. So, yeah.
So the topic at hand is electrodiagnostics, and I shared this story with you that I'll share with the audience at present. I remember back in 2000 joining the faculty of Southern College of Optometry, and immediately learned that only one faculty member was doing all the electrodiagnostic testing. And so I thought, well, I'm trying to navigate myself into this new type of optometric profession. I want to find myself a niche, so maybe I can assist in that endeavor. And so I went right to the library, checked out a book on electrodiagnostics, read the book, and said, whoa, this is crazy high science. No wonder there's only one person doing this. So needless to say, that is not how I developed my niche, and I pivoted immediately away from that. But now, obviously, technology has a way of delivering things to us that are simpler, quicker, easier, more facile. And so that seems to be where we have come today with regards to new items on the optometric marketplace for electrodiagnostic testing. Would you agree?
I totally agree. It's funny, your story about, back in 2000, going through what you went through. I'm a graduate of PCO. I graduated back in '98, and there was electrodiagnostics at the Eye Institute somewhere. And I couldn't even tell you where it was. I knew it was there because we heard rumors,
Right.
But most likely it was, in a research facility or in a basement room where you had to dark adapt people anyway. So it's a good place for it. But we never actually worked with ERG or VEP, that kind of technology on a regular basis in any of our clinics, either primary care or the glaucoma clinic, the PEDS clinic. We learned about the applications of that technology, Chris, but we never actually functionally use that equipment in clinic or to manage patients. So it's like we knew about it, but it almost was, we were led to believe it wasn't all that important, really. It's like you said, it's high science. It's beyond what you're going to do in clinic.
Yeah, for sure. So you mentioned ERG and VEP. So the latter being an opportunity to document visual potential, and then ERG, from my perspective, directly analyzing two retinal layers, and then indirectly perhaps a third, but really looking at function of these cells, and are they performing to the level that they should be performing at? Are you incorporating both of those assessments in practice routinely, or are you leaning more one towards the other? Is there another that I'm leaving out?
So really good question. As of now, I've only implemented and kind of got into the patient flow with ERG, with electroretinography. And primarily there's different protocols that we utilize, more specific to different disease types. And primarily what I'm using it for in my clinic is for monitoring patients with diabetes. So we're using what's called a full field flicker ERG. We're assessing the overall health of the retina. And the way I describe it to patients, and they kind of get this, it's a good way to kind of, an analogy that they kind of can embrace, is it is to the eye what an EKG is to the heart. We're going to look at a waveform essentially and just see whether or not the signal that your retina is picking up and sending back to your visual cortex, is that signal nice and strong, and is it fast? And I tell folks, just like your heart, if those retinal cells are either sick or not terribly healthy, you're not going to be able to take that light signal and transmit it quickly and with a high signal strength. So I typically have some documents in my exam rooms that show what a normal waveform would look like. And I typically will then show a patient after we run that diagnostic test, that functional test, what their waveform looks like. And I say, this is what we're looking for. The height of these waves, that's telling us how strong your signal is. And the distance between the peaks, that's telling us, how fast that signal is. And here's normal and here's you. And we now have a tool to monitor whether or not your retina is healthy. And can we improve that? So for patients with diabetes, the big question is, as optometrists, what can we do from a management standpoint? Well, a lot of it is patient education. It's, talking about patients, listen, these cells might be sick, but we don't know that they're dead. We can intervene here. It all boils down to, really good glucose control, talking to your PCP or your endocrinologist, and getting things under the best possible control. So it's a great visual too, Chris. What I love about it is that we've got something that patients can look at. And then much like IOP is for glaucoma patients, they know that number. And with ERG, with this diabetes protocol, we get a quantifiable number called a DR score that our patients can then track over time, that we can track over time to make sure we're getting better control. So it's
in the category of diabetics, are you talking, you're doing this on pre-diabetics, disaster diabetics, somewhere in the middle, or everyone?
Hey, Chris, I just lost you for a second. Could you repeat that question?
Sure. So you mentioned that you're targeting diabetic patients for this ERG. Specifically, are you really looking at pre-diabetics, your disaster end-stage diabetics, or the whole gambit in between?
I'm so glad you asked that question, because a lot of it boils down to utility in the clinic. And we've instructed all of our technicians that if they see any diabetic retinopathy on a patient, if there's any bleeding whatsoever on our full field optomap or fundus photography, that patient gets an ERG today. So those are folks that we know are actively having some issues. And what I do tell my patients as well is that even though we're seeing you today for your exam and we're seeing bleeding back there, that it shouldn't be there. So we want to make sure we find out what your baseline is today. we could have missed episodes of diabetic retinopathy over the years because
Sure.
I don't see you that often. I might see you 2 or 3 times a year at the most. So I just tell folks, let's get a baseline. Let's find out what the functional level of your retina is today. And as the years go by, my job is to make sure that we don't just assess the structure of how your retina looks. We got to know how your retina is functioning. Those two things, marrying structure and function in testing for patients with chronic diseases, I think is really important. We should not be just relying upon the structural, how the retina looks. We should know how it functions as well. So yes, the answer to your question is straightforward. It's a long, long answer to a short question. We are doing that test on every patient with diabetic retinopathy of any kind.
Got it. So then is it confounding at all to have patients who have diabetes and diabetic retinopathy with concurrent alternate systemic disease with alternate concurrent retinopathy? And how does that play out?
Yeah, confounding is the word. So I had a brilliant professor at PCO, and he said the following quote that I use every day in clinic. He said, "Just remember, Tim, your patient can have as many diseases as they darn well pleases." And what I love about that is that I say it to patients because they get a chuckle, but it also tells us there's a lot of variables at play here. And I know that with the DR score and that protocol that I use my ERG for, I can kind of tease out some of what could be causative of the bleeding I'm seeing back there. Because you're right, a lot of these folks will have concurrent microvascular diseases, where they've got hypertensive issues or hypercholesterolemia. And so, yeah, it's a good question. I feel like regardless, we're going to rely a lot on our patient history. We're going to rely on whether a person has been, is either on a medication for diabetes, is on insulin, has a family history of type 2 diabetes. My patients who've had a history of gestational diabetes, we have that conversation as well, or folks with diagnosis of prediabetes. So yes, I think there are definitely patients, Chris, I'll tell you, like I don't see diabetic retinopathy, but I'll run that test and just no charge them just to get that baseline. If there's a history, a situation that they describe, or I had a patient today actually, and he had a diabetic third nerve issue about 5 years ago before I had the ERG in my clinic. And I said, "John, I just want to run this test. I've never done it before. You're doing well. Your A1C looks good. You're under good control. You're at 82% on your time and target on your Dexcom. I just want to run this and just make sure I get a baseline for where your retina is functionally." And what was interesting is, he had that diabetic third nerve on his left side. And it was interesting. The ERG shows pupil response in addition to the waveform. And the pupil response in that left eye has never fully recovered. So I said, "John, look at this, bud. What I'm seeing here is a functional test that shows that episode from 3-4 years ago did cause some significant permanent damage to the functioning of your retina. Right. But now I know where you are today. I know your DR score. I've got your baseline waveform. We're going to watch this real closely. I've got a really good objective functional test. You basically do nothing but look straight ahead. And I can measure how you do functionally for the rest of your life with a little simple, handheld ERG."
That's perfect segue into what I was going to ask you next, because this podcast is a brand agnostic. This is not promotional. We're not paid speakers to talk about the product that we will eventually talk about here in a moment. But if I wasn't excited about it, I wouldn't even be bringing it up as a topic. But to start, I want to push back a little bit and see how you react. So, sure. Diabetes and diabetic retinopathy is so keenly connected to ECPs because it's one of the diseases, we see findings, and as a patient obtains better control or conversely loses control, things get better or things can get worse, and it's incredibly fast and quick. And so what I'm saying is I can see that. I can see the retina. I can see things improving. I can see things worsening. Why do I need a score when it's something that I don't have trouble managing, I don't think, today?
So I think the way I guess I would think about that just slightly differently, and I will use the analogy of macular degeneration, AMD, another topic I'm passionate about, another chronic, potentially blinding eye disease. And when we were trained in school, the way we were trained to, I guess, grade everything, Chris, was on a structural finding. So your intermediate dry AMD person, has a certain size drusen, right?
Sure.
Your person with proliferative diabetic retinopathy versus non-proliferative has a different number of microvascular changes in so many quadrants of the retina. And so that's where we're good at looking at what does the tissue look like.
Right.
And that's valuable, very valuable. And you're right, for many, many years, most of my career, I've been watching what that tissue looks like. So just to push back on your question a little bit, do you believe that if someone had a horrible, A1C of 10 4 years ago, had significant diabetic retinopathy, then gets under good control, A1C comes down to 6.5, you look in the back of the eye, there's no bleeding. Do you know that their retina functions today the way it did when they had that episode 3 or 4 years ago?
No, I kind of presume I presume the whole body's messed up to some extent, including the eyes.
So what's fun is we can assume, and I've done that. I've assumed that, the retina looks better, so the patient must be better. And the same thing, like using that AMD analogy again, like what I'm finding is that structure and function don't always correlate.
Sure.
I've got patients with AMD. I look at that macula, minimal to no drusen. When I run a functional test of the AMD patient, a dark adaptation test, I have patients who fail that test miserably. And research shows you let them go for 3 or 4 or 5 years and don't do anything, they're going to get drusen. That's the way that disease goes. I look at diabetes the same way. We can either look at it and say, oh, you're doing great. But that also is giving that patient the idea that now that I'm better, I can kind of go do whatever I want. And guess what's going to happen? It's going to go down that same pathway it did before. So having a number that we can use to monitor, to get the patient something to grasp onto, I think is really powerful.
Okay, so let's say let's create a fake patient. So you have a patient with bad diabetic retinopathy, a bad DR score, and so you're monitoring them closer, as is their systemic diabetologist. Their retina, their A1C improves slightly, their retinopathy improves, the DR score does not, or maybe it gets a little higher. Paradoxically, what then next? Is your diabetologist going to more aggressively treat, despite the fact there's not a systemic internal eye finding? In fact, it's gotten better, or is that just going to motivate you, the ocular managing piece, to monitor much more faster intervals or closer intervals?
Yeah, that's the number one thing you said there that I'll grasp on right away is anytime we see a chronic condition causing structural damage and functional damage, I see that patient more frequently. Absolutely. And the rate that someone improves, and you make a really good point there, Chris, is very variable. Patients that I've seen with type 1 diabetes for a couple of decades, you're going to have to wait a while to see that DR score improve if it's going to improve. What we may be seeing today is the new baseline. It may never improve, but I don't want it to get worse. It's all about, maintaining or reducing progression, right? So yeah, I really feel like it's important, I guess, not to oversell the technology. I think what I have noticed in my clinical experience, and I've been doing the ERG consistently for about 2 years now. This October will be 2 years. Is that what you described is not common, that you see a person with improvements in the systemic disease getting worse on an eye functional test. I've not seen ERG, DR scores get worse. I have seen them stabilize. And again, in those patients who are much higher risk and have had issues before. But in general, I do, and I'm going to slightly go off the topic, but there's a lot of really high quality research right now going into the benefits of certain types of supplementation and nutraceuticals when it comes to helping manage some of these diseases that are chronic, omega-3s and carotenoids, and not just for macular health, but just for general, for improving the health of any kind of neurological tissue. That's where those DHA and EPA are integral to a healthy brain and a healthy retina. And I tell folks every day, my patients, and they kind of look at me sometimes like I'm crazy, but I say, you don't see with your eyes. All your eyes do is gather that light, and how they gather that light and how they send that signal back to the brain is critical, but it's the brain that really matters. So retinal tissue is essentially brain tissue. We got to make sure that we're improving the health of all of that neurological tissue. So we do have conversations around supplementation for folks who might not be eating a good diet, or they may be lifelong smokers, for example, increasing the rate of free radicals in their bloodstream. So it's funny because the older I get and the more I do this, the less I feel like I'm just an optometrist or eye doctor and more of like a generalist. It's all linked. We got to make sure that folks get the message that they're not a pair of eyes to us. They're a human being, and we can help you out with some other conditions just by having those lifestyle conversations.
So let's get to the part where we talk about this technology.
Okay.
So, just a little bit of background. That the clinic that I work in, we have the older unit. That's more of a big piece of equipment on a tabletop unit, and you have a more modern, same company, same manufacturer, handheld unit, which you can take patient to patient, exam room to exam room, and potentially much faster, easier, quicker, like technology has found a way to become, which we talked about before. So please introduce us to what we're talking about here.
Sure. So just a little bit of quick background. There are two different manufacturers. In fact, I believe the one you're talking about is now owned by, can I say the name of the company, Chris? Or?
Sure.
Yeah. So Lumathera is a company that owns right now the diopsis technology. They also own a device that I've used for years called an Adapt DX Pro. That's the dark adaptation device I use for my AMD patients. But they are now the ones in that diopsis space. The other company I've worked with my ERG is called LKC Technologies, and that is the handheld. What's great about it, besides it being such a small footprint and being handheld, is that it's tech driven, but it's very simple and easy for our technicians to learn. What's really important about the test itself is its repeatability. We've got two techs that are the primary runners of our ERG testing, and they've gotten very, very good at just the positioning of the electrodes, for example. What's nice about the electrodes is they're very easy to place. You basically, our technicians clean the skin down below there, place the electrodes, and then simply hold the device up to the patient's eye. And all they have to do is, as long as they hold their eye open and look straight ahead at a fixation target, the flicker, the full field flicker ERG is performed. It takes no more than between 15 and 30 seconds, depending on the protocol. There is a protocol that's also used for glaucoma. And there's one that's called the flicker protocol that's just to kind of give a general health of the back of the eye assessment as well. So yeah, we've liked that because it's actually really easy to run on the fly. If a patient, we do see diabetic retinopathy, our tech can just run out, grab it, and run the test in real time during the eye exam without having to have the patient back for a follow-up.
So are you having your patients dark adapt, or if so, how long does that add to the
Good question. So for our patients who have diabetes, one of the areas being measured besides the actual signal strength and speed is the constriction and dilation of the pupil. It's intimately related to the retinal functioning. So we do not do any dilation with folks who do ERG. They don't have to be dark adapted. No, there's no dark adaptation required. Okay. It's just in a regular exam room lighting typically.
If I chose to do the test after dilation, obviously I would not have the pupil assessment, but would allow me to fulfill the rest of the data collection.
So the DR score is based on knowing the pupil response. There's an algorithm that involves three things. It is each eye is going to measure each eye's signal strength, signal speed, and pupil response. And that DR score uses all of that data to determine the likelihood that that patient would need to have an ophthalmological intervention within 1, 3, or 5 years, that being like an anti-VEGF injection. So the higher that DR score goes, more likely that patient's going to have an intervention with a retinal specialist.
And what's the range of DR score from low to high?
Yeah, so it's typically a score from 10 to 30. And I typically see the normals mostly in the low to mid teens, 13, 14, 15. I have seen patients as high as 30, 29, 30. Those are folks with significant active bleeding, and oftentimes right in the middle of a
Got it. So besides the extreme end, 29, 30, are there any other numerical values that cause you pause?
Yes, I would say the one that causes the biggest pause is a patient who's had the DR score, the ERG performed in the past, who then has a significant increase.
Got it.
And typically, if it's an increase of 3 to 4, that's pretty significant. Even if they go from, say 17 to 21, 21 is still a passing DR score. The magic number is 23.5. But the fact that it went that far, that quickly in a repeatable test, and that's something that we had to assure ourselves also. And you may be the same way as I am. I'm always a cynic until a technology proves itself to me. So we did a lot of testing of our own doctors and technicians for the first couple months, looking for repeatability, making sure that we were putting the electrodes on correctly and getting the same kind of test results over and over again on the same patient. So that's important too, making sure that you've got consistency in the testing, consistency in the electrode placement. But anytime we have that kind of consistency and we're seeing a significant increase in that DR score, that's a bit of a red flag. That's someone I want to have that conversation again with their generalist, their PCP, the endocrinologist, and with them about, something's not right here. We're going in the wrong direction. Your DR score is increasing. So
what about disparity between the eyes or significant asymmetry?
Yes, the DR score is a combination of the results from the two eyes using the data. So we don't just do one eye or the other.
Got it.
Yep.
So you don't have the dark adapt. You can bring it right to the patient. You talked about being able to show the patient something besides the numeric value. Are you showing something on the screen of the device? Is it printing something? Is it sending it to your laptop or your EHR? How are you demonstrating something visually?
Yeah, excellent question. Yeah, the device itself is so small. There's no ability for the device to there's nothing really to show the patient, I guess is the best way to put it. But we simply take the device, put it in a cradle, and it's linked to a printer, and it just prints out the patient's result in a typical sheet of printer paper. I bring that into the exam lane and just show it to the patient. Hey, this is what we're seeing. It's no different than pulling up, an Optos or an OCT screen and showing the patient. But I don't know, and maybe it's a me thing, but there's so much value in having something visual to show people. It's why I think we love having a fundus camera as well. Like, I can tell you've got bleeding on your retina, but I think it's 1,000 times more powerful to show you on a screen, listen, this is your retina today. Here's what it was last year. This is making me nervous, and here's why.
Sure.
So having something visual, and I have patients who ask to take that home to show their spouse, especially those patients who had a DR score at 27 3 months ago, and now it's down to 21, and the retina's looking better. They want to go show their spouse that their number's better. So again, I think patients, and I think optometrists as well, we kind of latch onto something quantifiable. And I believe what's happening right now, in fact, our clinic is part of a study trying to find a similar type of a DR type score for glaucoma patients, utilizing the same ERG technology, a different protocol called the photopic negative response. We're trying to find a way to quantify that to look at risk. What looks risky, what is more risky versus a PHNR that looks like this. So that's something that, again, I think once we get there, that research is ongoing. Huge shout out to Dr. Michael Simbor at Nittany Eye Associates in Pennsylvania. He's kind of leading the charge on that. But there's more to come, I think, is probably the best way to put it. I think right now I've got the most confidence in the results of the DR score because of the research and science that went into that DR score.
Cool. Well, just a few more questions, if it's okay.
Sure.
So first off, there is a CPT for performing of this service to patients. But do you use that CPT? Is it a reimbursable CPT, or is it just a placeholder? How does that end up working?
Yeah. So, Chris, and if you had used another version of an ERG, there's hundreds of codes for ERGs across the board. So I utilize probably the same 10 or 12 on a regular basis. And just to be clear, we also run the ERG on other conditions besides diabetes. We've got patients with congenital optic atrophy, for example. We've got patients with different kinds of congenital macular and retinal diseases that we'll run this on. And again, 99% of these tests, yes, are reimbursable. There's a CPT code. There are hundreds of diagnosis codes. So we get reimbursed, I would say, a nice level. I mean, it's a good reimbursement. But that being said, like I mentioned earlier, there's definitely cases where I'm a geek. I just want to know where this person is today. I wouldn't mind just having a test done. And there are definitely cases where I'll just ask my tech to run it, and I'll comp it just to get the information.
So you led us perfectly my next question, which is when you get past the diabetic patients and past the DR score, we're still going back to looking at a two-dimensional graph with wave and amplitude height and distance between waves, right?
Yes.
Got it.
Exactly right.
So we have discussed the technological advancement of electrodiagnostics to become more simpler, facile, easier to use, quick to use, staff to use, not singular experts to solely use, hidden in a closet that was impossible or near impossible to find. Where do you see this going, say, in the next 5 years, and maybe even a bit longer out, in the next 10 years? Is this going to be mass acceptance? Is it going to be standard of care? And obviously there's no right or wrong answer.
No,
is it going to be a few select practices? What's your prediction?
So I think what I'll use as a reference is just some of the feedback I get when I do quite a bit of lecturing, on chronic disease states and things. And when I bring up this device, there's a lot of our colleagues are very interested in something
Sure.
that has this ability. And if I were to look into my crystal ball, what I really love about the test over some other tests that we use for functioning of eyeballs is its objectivity. Patients despise tests with clickers, and the length of the test,
Sure.
the subjectivity, do I click it or do I don't, or do I not? And I think what was really nice to hear in the first few months of running the ERG was patients saying, this is awesome. It's easy, it's quick. I wasn't even dilated, and this is so much better than having to sit and run some of the other functional tests that we run. And I would hope that what we're going to see, to answer the first part of your question, Chris, is that it's expanded into other disease states. And we also, we have the research behind using ERG to monitor and manage chronic diseases. If we could find a way with that same handheld device to do for the macula, a pattern ERG, or a VEP, there are abilities of the current device to do some VEP testing, like for pediatrics, for example. We are not utilizing it that way in our clinic currently. But I think there's that device itself, the platform can be expanded significantly just by changing out the protocols that are on board there.
Sure.
So it's exciting. I understand that some tests need to be subjective, but I feel like if we could kind of get, as a paradigm shift, our peers and our colleagues into this mindset where we have to follow how things look in the structure, but we really got to start doing really good functional testing as well to make sure we're not losing functioning without, missing it by just looking at structure that we don't see because we don't see patients often enough to see it when it happens. So yeah, I'm a big proponent of marrying those two things. Structure and function are critical in those chronic disease states.
Yeah, it makes perfect sense, Tim. You've really accelerated my excitement about this. I started looking at it a bit ago on the research side, because obviously it has clinical applications, but as we continue to push the envelope, especially as you mentioned with more disease states, there is opportunity on the research end as well, and really a necessity for it.
Absolutely, it's exciting, and this is what keeps us, loving optometry. It's a profession that doesn't sit still. There's lots of innovation going on, and that's what keeps me smiling after 26 years.
Fantastic. Well, thank you again, Tim, for joining us, and I'd be delighted if you join us again in the future.
Hey, Chris, thanks for having me on. I appreciate it, and look forward to next time our paths cross, my friend.
You got it.
Take care.
Class is ended for today, and we have no exams or grades approaching. Please email me at foureyeedprofessor@gmail.com if there are topics that you would like to hear and see through a professor's eyes.